Harold is a young man in his early 20s who arrived at our clinic today on a referral from his speech therapist. Beyond his visible facial anomalies, he requires significant daily respiratory support to survive. As documented in this initial presentation panel, a physical exam immediately reveals a distinct triad of features: downwardly slanting eyes, a depressed midfacial area, and a small, underdeveloped mandible. He came in reporting progressive palatal soreness, difficulty swallowing, and a speech pattern that has become increasingly hypernasal over time. Harold's history records a sequence of major interventions: a childhood tracheostomy, nightly CPAP use to prevent airway collapse, and surgical corrections for a lower eyelid coloboma and microtia, alongside a cochlear implant. Currently, he wears a prosthetic obturator. As noted here, this device is meant to seal an opening in his palate, separating the oral and nasal cavities. But his obturator fits poorly, failing to maintain that seal. Each of these surgical interventions traces back to a single, highly specific failure during the first few weeks of embryonic development. The unifying diagnosis here is mandibulofacial dysostosis, more commonly known as Treacher syndrome. Harold noted that he inherited these traits from his grandfather. That tracks exactly with the autosomal dominant inheritance pattern typical of this condition. The condition is triggered by a mutation, most frequently found in the TCOF1 gene. This genetic error disrupts a crucial cellular process: the migration of neural crest cells from the embryonic neural tube toward the developing head and neck. To understand Harold's facial structure, we have to look specifically at how this cellular deficit starves the first and second pharyngeal arches of their required building materials. Harold's lifelong struggle to maintain an open airway, requiring that childhood tracheostomy and his current CPAP machine, stems directly from his small jaw and depressed midface. This diagram maps the pharyngeal arches. You can see how the first arch, highlighted in green, develops into the primary skeletal framework of the face, including the mandible, maxilla, and zygomatic bones. These specific bones form through one of two embryonic pathways: intramembranous or endochondral ossification. As this slide outlines, intramembranous ossification occurs when bone develops directly from a mesenchymal membrane. This is the process responsible for building most of the viscerocranium, the facial skeleton. Because intramembranous ossification relies so heavily on migrating neural crest cells, conditions like Treacher preferentially disrupt this pathway, leading directly to severe facial flattening and micrognathia. When the mandible fails to elongate, it forces the tongue base backward. This creates a mechanical collapse of the posterior airway, leaving surgical bypass as the only reliable option for oxygenation. Harold's respiratory history is the direct physical consequence of stalled intramembranous bone growth. We also have to account for his auditory deficits, microtia of the external ear, and profound conductive hearing loss, requiring a cochlear implant. Looking at this diagram of the pharyngeal apparatus, the external auditory canal develops from the first pharyngeal cleft. When development stalls here, the external ear structures remain malformed or closed off. Deeper inside, the middle ear relies on three tiny bones to conduct sound: the malleus, incus, and stapes. These are derivatives of the first and second arches. This table breaks down those skeletal derivatives. Under the first arch, Meckel's cartilage undergoes endochondral ossification, forming from a cartilage model rather than a membrane, to become the malleus and incus. The second arch, containing Reichert's cartilage, forms the stapes. While these are endochondral bones, their cartilaginous models still depend heavily on the neural crest cell copulations that failed to arrive. Consequently, his hearing loss is the result of a dual failure: an external cleft that never fully opened, and middle ear cartilages that never properly ossified. Harold's hypernasal speech points to velopharyngeal insufficiency, compounded by a persistent 4 mm opening, or fistula, in his hard palate. This schematic illustrates the development of the face between weeks 4 and 8. The architecture is built from 5 primary facial prominences. To form a complete upper lip and palate, the medial nasal prominences must grow and fuse flawlessly with the bilateral maxillary prominences. Because the maxillary prominences are derivatives of the compromised first arch, they frequently lack the volume to meet in the midline. This incomplete palatal fusion leaves a permanent communication between the oral and nasal cavities. Even when surgically repaired, the resulting soft palate is often too short. It cannot elevate fully against the back of the throat, preventing the airtight seal necessary for normal speech resonance. Managing this requires either further surgical intervention, like a pharyngeal flap, or relying on the prosthetic obturator Harold currently uses to block the airflow. The fistula in his palate is a literal, physical remnant of embryonic space that never successfully closed due to arch underdevelopment. Looking at the pharyngeal arch derivatives map, we isolate Harold's condition to the first 2 rows. In the muscle derivatives column, the first arch supplies muscles of mastication via the trigeminal nerve, and the second supplies facial expression muscles via the facial nerve. Reviewing this breakdown of ossification reveals a critical distinction. The neural crest cell failure in Treacher Collins is largely restricted to the viscerocranium. The neurocranium, the bone enclosing the brain, develops normally, which is why intellectual ability is preserved. The presence of downward slanting eyes, mandibular hypoplasia, and ear defects confirms a failure of neural crest cells to populate the first and second pharyngeal arches. Understanding embryology removes the mystery from complex clinical presentations. It serves as the mechanical blueprint, explaining why a single genetic error inevitably creates this precise multi-system surgical history. By tracing the pathway of migrating cells, we predict facial architecture. Clinical medicine, ultimately, is just embryology observed in the adult form.